All right, ready.
Eh, So we are live now. With all your permission, I'm starting this session.
Okay. So
Good
is my
evening,
face
everyone
seen or
present
not?
here.
Sorry.
Sir, everything is visible, sir. I'm starting this session.
Right.
A very good evening to everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker, doctor, with great honor, none other than Dr. K. Sarath Chandra, sir. Let me share some of the achievement of this, sir. Sir has done MBBS, MD in medicine, DM in cardiology, FACC, FESC, FCSI, consultant cardiologist at TX Hospital, Hyderabad. And today, sir is going to discuss on a topic heart failure and diabetes. Let me tell you overview of the topic before starting this session. Heart failure in people with diabetes present a significant medical challenges as the diabetes is a major risk factor for this condition. The combination of high blood pressure levels and the diabetes related complication can weaken the heart muscle, impairing the cardiac function. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Thanks to your organization for giving me this opportunity. Although he has done a great justice to me while introducing me, I just want to add a couple of points. I was editor of Indian Heart Journal from 2012 to 14, and I was elected president of Cardiological Society of India for the year 2018. So now let's go ahead with this subject, heart failure among diabetics. This is a subject which is pretty close to my heart because we see day in and out patients of heart failure today. Today, cardiology practice has changed quite a bit compared to the times when we just became cardiologists. Today, we are seized of the problem of two epidemics in our society. One is coronary artery disease, about which you all are pretty well aware of. But the other thing is the heart failure. Now, heart failure among diabetics has a number of different connotations, and let me take you through some of them. Now, I'm going to discuss this subject. Oh, this cursor is not moving. 1 second. Mhm. I'll just stop sharing. Are you able to hear me for us?
Yes, sir. I can hear you, sir. You are audible, sir.
This slide is not changing.
Just click on your screen, sir. Just click on your screen and just go to left. Just click on your screen and just click the keyboard arrow next.
Oh, you want me to do it from here?
Yes.
Okay.
No.
All
Yes.
right.
Yes, sir.
Good. Good. I'll do it there. So, I'm going to discuss this under a few different headings. One is the incidence and prevalence of heart failure. The other is the pathophysiology, the risk factors for development of heart failure among diabetics, the prognosis, how to treat heart failure among diabetics, and how to treat diabetes among heart failure patients. All right. Now, the fact that coronary artery disease is seen at a much higher incidence among patients of diabetes is very well known. But not so well known is this fact that patients of diabetes are at an increased risk of heart failure. It is generally agreed that diabetics have got a 2 to 5 times higher risk of developing heart failure. We will come to that again further down the slides. But I want to tell you that not only diabetics are at a higher risk of development of heart failure, once they develop heart failure, their chances of mortality are 60 to 80% higher chance of death and all-cause mortality compared to those patients of heart failure who do not have diabetes. So they tend to develop it more often, and once they develop it, we tend to lose them more often. All right. So that shows that the prognosis is considerably worse among diabetics with heart failure compared to non-diabetics with heart failure. Now, among so many risk factors which we know of for development of heart failure over course of time, like overweight, obesity, myocardial infarction, advancing age, male sex, hypertension, valvular heart disease, left ventricular hypertrophy, along with them, diabetes is a very important risk factor. This is further to highlight the same point. All right. Now, diabetes is frequently associated with heart failure, as you can see here from some of these pivotal trials, what we call. These are all heart failure trials: Paramount, Paradigm, FSS, Charm Alternative. All these trials are known to many of us, and FSS used, the MRA antagonist, and Paramount and Paradigm used, the RNA therapy versus different agents in patients with heart failure. Charm Alternative used candesartan. And now, among all these heart failure trials, diabetics formed nearly 30 to 40% of the total population who were recruited for these trials. It shows the paramount importance of uh, you know um, heart failure and diabetes. Okay, now this is an important study. It will tell you further about epidemiology of heart failure among diabetics. Now, this is a publication way back in 2004, but it is such a seminal publication that I would like to bring it to you. It was published by Dr. Nichols. It is a retrospective cohort study of 8,000 plus patients of diabetes and similar number of matched controls who are also 8,000. And then they were followed up over course of time to look at what happened. How many of them developed heart failure? None of them had heart failure at baseline. And then when records were looked at for 72 months, indicating 6 years, the incidence of development of heart failure among diabetics was 30.9% versus 12.4% among non-diabetics. So the rate ratio is 2.5. That's why the general understanding that diabetics are 2.5 times more prone to develop heart failure. Among younger subjects, the difference was greater. Now, that will be shown to you in this next slide. You can see this comparison of incidence of diabetes at 45 years of age. You can see diabetics 4.5 versus non-diabetics 0.4. But as the age advances, you can see that among diabetics, the heart failure incidence increases. But among non-diabetics also it increases, but it increases little later. So diabetics tend to develop heart failure not only more frequently, they develop it significantly younger point of time. Okay. Now this slide again shows that the chances of development of heart failure among this orange color graph shows development of heart failure among diabetics versus the blue color, which shows the incidence of heart failure among non-diabetics. And you can see here the difference is greatest at a younger age. As the age catches up, the difference in the prevalence of heart failure or incidence of heart failure becomes smaller and smaller. Okay, so that means there is a tendency to develop heart failure among all of us as we grow older, but this tendency comes earlier among diabetic patients. The non-diabetics will eventually catch up. You can see it further in another slide. You can see, of course, this can be left alone. And see, these are some of them are Cox regression analysis for development of heart failure for patients with type 2 diabetes. This is from the same Dr. Nichols data. You can see here, most of them are these factors which are shown. Age at baseline per 5 years, the incidence increases. So older the person, greater the chance of heart failure. Ischemic heart disease presence, it makes it 2.36 times higher. So is BMI. Most of them are statistically significant. Microalbuminuria, gross proteinuria, end-stage renal disease, duration of diabetes. The longer the duration of diabetes, greater the chances of development of heart failure. And you can also see here, mean A1C at the beginning of the observation. That's a very, very important. So if the patient came to you with only mildly uncontrolled A1C at the time of beginning of his diagnosis of diabetes, his chances of development of heart failure are less compared to somebody who has markedly uncontrolled A1C at the beginning of at the time the diagnosis of diabetes is made. All right. This is exemplified in another slide. Look at this. When you see these quartiles, less than 6.4, 6.4 to 7.1, and so on and so forth, when you reach 9 A1C, the highest quartile, the heart failure hospitalization chances are significantly higher. So at the time of diagnosis of diabetes, if A1C is higher, the chance of heart failure are higher. So probably that means the diabetes has been unrecognized for a longer period of time in those who have A1C much higher. And probably the disease also is more severe, and that makes him more prone for the development of diabetes. Okay. So these are multiple other trials. No, this is, we have to go here. All right. These are multiple trials, most of them multiple data sets, which have shown that the development of heart failure among diabetics is significantly higher. It is something very similar to what we have seen in the Dr. Nichols data. Okay, this slide we have gone through. All right, now here, the diabetes and effect of blood pressure control. This is from the UKPDS trial. You know, UKPDS is an old trial published many, many years back, 98, in BMJ and Lancet. What these trials have shown basically is control of diabetes, tight control of diabetes versus average control of diabetes. What is the effect on long-term outcomes? You know, UKPDS is a very old trial and very well-known, appreciated trial. Now, this is the first trial that has brought to the world's attention that if you give tight control of diabetes, you make the chances of a diabetic patient to develop various complications considerably less. You can see in this, the same thing is exemplified in this slide. You can see here, control of diabetes is important, but control of blood pressure is even more important. You can see here, the yellow color bars represent control of hypertension. The green color represents control of diabetes. You can see here, the control of hypertension has made much bigger difference than the control of diabetes. We are, of course, going slightly away from the talk, but that shows the importance that it is the combination of high blood sugar and high blood pressure that is very, very critical in determining the long-term worst prognosis of the patients. So it is important to control blood pressure, but even more so among those who have diabetes. Okay. So, you know, you may ask the question, what is the relation between diabetes and heart failure at the level of pathophysiology? There is a bidirectional relationship between diabetes and heart failure. You can see on the left side, on the right side, first, let us look at it. What we are seeing is the development of diabetic cardiomyopathy. If there is diabetes, these are all the various mechanisms through which it tends to lead to heart failure. Advanced glycation end products, deposition of advanced glycation end products between the cardiac muscle cells that can lead to fibrosis. There is increased fatty acid utilization, which is not considered good for the heart. Mitochondrial dysfunction, oxidative stress, development of inflammation, microRNAs development, mitochondrial dysfunction, and impaired calcium accumulation, and so on. So these are all the mechanisms through which diabetes can lead to an impairment of cardiac muscle cell contraction and eventually into the development of heart failure. The reverse is also there, that if you have a patient who has heart failure, that tends to affect the control of diabetes through different mechanisms. If there is undiagnosed diabetes at the early stages of heart failure, there can be metabolic effects of diuretics, particularly thiazide diuretics can actually worsen the condition of the severity of diabetes. There can be metabolic effects of beta blockers, hypoperfusion and congestion of pancreas and liver. These are, of course, seen in more severe heart failure that can lead to further worsening of diabetic status. There is increased catecholamine levels in the blood. There is increased sympathetic activity, which are detrimental, as we know, for heart as well as diabetes. And because of heart failure, patients' physical activity is reduced, and therefore that can lead to worsening of diabetic status. So this is a very well-known, a bidirectional relationship between diabetes and heart failure. This is a favorite slide of mine. All right. Okay, so here you see diabetes is associated with a worse prognosis in patients with heart failure. You can see here the top two curves represent over course of years what happens to the various bad effects, like cumulative incidence of adverse effects. They are higher among patients of diabetes, whether they have heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. The blue lines represent the curves among patients who do not have diabetes, and the top one represents HFrEF and lower one, the lowermost one is HFpEF. It shows that if you have heart failure, a non-diabetic also may have heart failure, but the diabetic heart failure behaves worse. So this takes home the same point. All right. Okay. So how do you treat these patients? What is the checklist? So when you have a patient of heart failure in a patient who has also got diabetes, the treatment of heart failure is same as what you would do in a patient without diabetes. For example, ARNI therapy has been shown to be equally effective among diabetic patients. The various anti-heart failure measures, the drugs like the MRAs or beta blockers, they all have shown pretty impressive results, whether you are treating a patient of diabetes or not diabetes. So you need to understand that when you have a patient of heart failure with diabetes, you treat him as aggressively as you would treat a patient without diabetes, but having heart failure. If you want to put a device like a CRT, go ahead. If you want to put an ASCD, go ahead. So treatment of heart failure does not really differ. Now, this slide we have already, I think this slide we have already gone through. Okay, so now the question of how do you treat diabetes among patients of heart failure? Now, there are so many points which are of interest. Now, let me take you through some of them. Thiazolidinediones, pioglitazone or rosiglitazone, they tend to induce sodium retention and worsen the heart failure, and so they must be avoided among heart failure patients. There is no doubt rosiglitazone has been out of the market for a long time now, and it's now clear that rosiglitazone worsens heart failure. Pioglitazone, whether it should be there, whether it should be used for diabetics or not, has been a controversy. Many countries have banned the use of pioglitazone. India, the ban comes and goes. But one thing is clear. If you have a patient who is prone for development of heart failure among diabetic patients, definitely pioglitazone also is a strict no-no. Incretins, the DPP-4 inhibitors, these are actually drugs which are generally considered as reasonably acceptable, except saxagliptin and alogliptin. The other gliptins, like sitagliptin, they are heart failure neutral. You need not worry too much about it. Metformin, the risk of lactic acidosis, what has been suspected for a long time. Today, we really do not think it is of great clinical significance, and metformin can be used in patients with heart failure without much of a hesitation. Sulfonylureas are generally considered having a neutral effect in relation to heart failure. But let me tell you, both sulfonylureas and insulin, they tend to increase the body weight of the patient. So if you have a patient of heart failure and his body weight increases because you are using these drugs, you have to keep in mind that you have to insist on the patient not to put on much weight, make an effort not to increase the weight. Because if the weight increases, the load on the heart increases, and therefore heart failure can actually become worse. I tell my patients, if you have heart failure, you lose 10 kilos of weight by making a good effort, then your requirement for the drugs can come down, your prognosis can significantly improve. All right. So, this is what the rosiglitazone, pioglitazone data shows, that if you use these drugs among patients of heart failure and diabetes, you definitely worsen their condition. Rosiglitazone particularly has got a significant incidence of heart failure development. All right. Some of these slides are not up to the mark, but all right. So now we come to a very, very, very seminal publication in relation to diabetes and medications. And let me take you through some of this data in relation to SGLT2 inhibitors, the outcome of the EMPOREC trial. You know that in 2008, the FDA has come down and said that, look, you guys, if you bring in a new molecule for diabetes control, do it. But you have to show that the new molecule, the said new molecule, is not harmful to the cardiovascular system. This has come because of the rosiglitazone data. And so everybody has been asked, if you are bringing a molecule, you demonstrate cardiovascular safety in relation to your new molecule. So when this this SGLT2 inhibitor came into the picture, they said, let's do an EMPA-REG trial to show that it is having safety in relation to cardiovascular endpoints. But what happened was, when they looked at the data, it is not only safe, it is actually very, very beneficial. And rest of it is history, as they say. The empagliflozin reduced heart failure hospitalization by 35%. And later, whatever gliflozins have been brought in, the other SGLT2 inhibitors, they all have shown, be it dapagliflozin or canagliflozin, they all have shown considerable reduction in chances of development of heart failure and need for heart failure hospitalization. In fact, EMPA has shown even total mortality also has come down when it was given to diabetic patients. Now, the EMPA-REG trial was done among patients who have diabetes and who are high-risk patients for heart failure. Most of them had coronary artery disease. Most of them have worsened renal function, and they are known that they are likely to have, they are at a high risk of heart failure. And then they are high CV risk patients. And then they were shown that the chance of heart failure have considerably come down. The overall mortality has come down. And that became a big talking point. And this publication came in 2015. And after that, there was no looking back for the SGLT2 inhibitors. Now, let me show you some of the data in this EMPA-REG outcomes and CANVAS. See, CANVAS also showed benefit for CANVAS program, which used canagliflozin, also showed benefit. And if you look at heart failure hospitalization, see at the bottom, the hazard ratio for EMPA is 0.65 and Cana it is 0.67, almost same. So there is a 35 to 37% reduction of heart failure. So that's a very, very important thing. The other things like mortality due to myocardial infarction is not really significantly reduced, but all-cause mortality was reduced with empagliflozin, but not so with canagliflozin. All right. Okay. Now look at this. This is the data from the same EMPA-REG trial. What happened to patients of those who are on empagliflozin and those who are on placebo? It shows that the empagliflozin curve has separated from the placebo curve very early in the course of follow-up of these patients. Right at before 6 months, the curves are separated, and it's clear that if you have today a diabetic patient, more or less usage of these SGLT2 inhibitors is almost like a class 1 indication, particularly if they are prone for heart disease. If you have long-standing diabetes, it is an indication. If you have diabetes patient who has already had coronary artery disease, it's an indication, and so on and so forth. And today, of course, renal indication is also added because SGLT2 inhibitors greatly improve the renal outcomes. There is plenty of data. Some of it I will be sharing with you. And today, not only the gliflozins or the so-called SGLT2 inhibitors improve cardiac outcomes, the heart failure outcomes, they also improve the renal outcomes. The chances of development of end-stage renal disease are significantly reduced. The rate of fall of GFR among these patients as you follow them is considerably improved. The rate of fall of GFR becomes relatively flatter if you use SGLT2 inhibitors. All right. And what you can see here, EMPA-REG outcome, patients without baseline heart failure. This is, of course, old data is probably not very relevant because now you have got plenty of data among patients with heart failure. The EMPEROR reduced and EMPEROR preserved and DAPA-HF trial and DELIVER trial. So much of data among patients who have heart failure at baseline. Among them, you used SGLT2 inhibitors and you have shown excellent outcomes compared to placebo. This, of course, this is the data that was taken out from EMPA-REG, showing that a small number of patients out of the total patients had heart failure at the baseline. Actually, it is an exclusion criteria, not to include patients of heart failure. But even when you have this, you have certain number of patients creep into many of these trials while having some degree of, to an extent, exclusion criteria. But here you can see that among patients who are prone for heart failure, not having heart failure at baseline, and even they have benefited significantly from reduced chances of heart failure. So here, empagliflozin and heart failure hospitalization, patients with low to average heart failure risk also, there is a 29% reduction of heart failure chances. And here, this is the ABC risk score they used for looking at dividing these patients into low to average risk, high risk, and very high risk. And if it is low to average risk, there's a 29% reduction of development of heart failure. And when they take the group with a high risk group, there is a 48% reduction. And very high risk group also, there is a 45% reduction. Clubbed together, all of them, there is a 35% reduction of development of 35% reduction in the need for hospitalization for heart failure. That's a great benefit. So here, okay, this we can skip it. Okay, so what happened? By treating 1,000 patients with SGLT2 inhibitor over 3 years on top of standard of care, that means you have given all the best possible drugs to the patient, and over and above that, you have given a gliflozin, in this case, an empagliflozin. And then what has it shown? It is possible to prevent 20 events of 3-point MACE, 27 deaths, and 15 hospitalizations for heart failure at the cost of slight increase in genital infection. Actually, this fear of urinary tract infection is no longer there. We don't really see it. I must have given very big number of patients SGLT2 inhibitor. We hardly come across any patients who come and say that I'm having urinary tract infection. Genital infections might possibly be higher among patients with among female patients. So we tend to advise female patients particularly to follow strictly genital hygiene. Okay, so now there was an initial fear of amputation, particularly when you use canagliflozin. A lot of water has flown under the bridge. People were concerned about small gangrene and small amputations. But today you have plenty of data. There is no need of fear of higher risk of amputations for these patients on SGLT2 inhibitors. It is no longer true. This was original fear among the Canvas program patients, but it's no longer true. Even with canagliflozin, the later credence trial, etc., they have not shown any evidence of increased risk of amputations among these patients on SGLT2 inhibitors. And you can see later, I will quickly take you to the 2-3 important slides which I want to show you, and then I'll come back on some of these slides because that will okay, right. Let's look at these data. Now, the emperor reduced and emperor preserved are the trials done among patients with heart failure with reduced ejection fraction and patients of heart failure with preserved ejection fraction using empagliflozin. Similar trials were done with dapagliflozin. The one with reduced EF is DAPA-HF trial, and the preserved EF is DELIVER trial. All these 4 trials have very clearly shown that if you use these patients in patients with established heart failure and diabetes, you can show considerable improvement in prognosis. These trials have in fact randomized patients without diabetes. 50% of the patients, nearly 50% of the patients were non-diabetics. Because of the data of EMPA-REG trial, they said that let us try it in non-diabetic patients and see what happens to heart failure. Once again, the benefit is equally good. In fact, some of the numbers show that among patients who did not have diabetes, the numbers are slightly better compared to those who had diabetes. Of course, that's not statistically significant, but at least it is clear that whether you have diabetes or not, if your patient has got heart failure, give him SGLT2 inhibitor, he will definitely benefit. Whether he has preserved ejection fraction or reduced ejection fraction, give the SGLT2 inhibitors. Once again, there will be benefit. That is how, on the basis of these data, people started talking about the fourth pillar of treatment of heart failure in relation to pharmacology. We know that mineralocorticoid receptor antagonists uh, give a benefit of nearly 35% reduction of mortality. We also know that ACE inhibitors, RB or ARNI, which came even later, they also show great benefit. That is the pillar 2. And then beta blockers, which are very established drugs for reduction of mortality, arrhythmias, worsening of heart failure status. These three were considered the original three pillars, and SGLT2 inhibitors have joined as the fourth pillar of treatment of heart failure. So, today the gliflozins have come in a big way in improving the outcomes of diabetics with heart failure and non-diabetics also with heart failure. Now, I'll quickly go back and show you some of the slides in relation to the mechanism by which SGLT2 inhibitors actually help these patients. Now, I'll show you this, and let me start here. Okay, so when you use the empagliflozin in this particular data, there is a 7 to 8% reduction of plasma volume independent of baseline EGFR. Compared to see the top curve, the placebo curve, the curve with empagliflozin shows very clearly that there is a reduction of plasma volume. Now, the plasma volume is reduced, but the interstitial volume also is reduced. And the reduction of interstitial volume is greater with empagliflozin, with gliflozins compared to ordinary diuretics. The routine loop diuretics reduce the plasma volume as well as the interstitial volume, but here the interstitial volume is reduced to a greater extent than the plasma volume. So here you can see blood volume reduction, SGLT2 inhibitors, there is a fall. Loop diuretics also, there is a fall. The interstitial fluid volume reduces and remains sustained, and therefore, some people loosely said that SGLT2 inhibitors are probably expensive diuretics. It's not correct. SGLT2 inhibitors do have a significant diuretic effect. In the initial days, both sodium and glucose are responsible for the diuresis effect. Later, what remains is the diuretic effect, which is contributed by the glucosuria, which remains sustained. The sodium, for some reason, the loss of sodium tends to become smaller over course of time, but the glucosuria continues, and to that extent, the diuretic effect continues. Loop diuretics reduced interstitial fluid volume by only 78% of the reduction of blood volume, while here it reduces 2 times greater than the blood volume. Okay, so then there are so many theories that have come. Nobody really knows how the SGLT2 inhibitors improve the cardiac outcomes, heart failure outcomes, but these are all theories. Here you can see in this slide, like diuretics, empagliflozin or any gliflozin may result in transient natriuresis and increased urine volume, reduction in plasma volume, increase in the renin-angiotensin system. But unlike diuretics, the gliflozins come with a glucosuria, in turn producing osmotic diuresis, caloric loss, blood glucose lowering. So there is a lowering of blood glucose and a reduction of A1C, and there is a peculiarly a lowering of uric acid also. And we know that uric acid is a bad prognostic factor in patients with heart failure, for that matter in patients in general. And thiazides can actually increase uric acid, but gliflozins reduce uric acid, and increased sodium delivery occurs to macula densa, which is a very, very important thing in the prognostication of the patient. Okay, so they produce caloric restriction, mimicry, reduction of A1C, reduction of blood glucose, fasting or postprandial. There is a volume offload. There's a slight reduction in the blood pressure of about 2 to 4 millimeters mercury. So the SGLT2 inhibitors slightly reduce the blood pressure also. There is a hemoconcentration, which also might be responsible for the improvement. And there's a metabolic efficiency, that there is a substrate switch and reduced metabolic stress. Okay. All right. I think we have spoken enough about heart failure and okay. Right. So the take-home points are heart failure is a serious problem among diabetics, both in increased incidence and worse prognosis. Multiple risk factors. Worst probably is the uncontrolled glycemia for a long time. So you leave glycemia, the hyperglycemia, uncontrolled for a long time, you probably tend to make the patient's condition worse, not only in terms of nephropathy, neuropathy, and retinopathy, but also probably cardiomyopathy. Treat heart failure in the same way as you would a non-diabetic. Control glycemia cautiously and avoid hypoglycemia. Choose your anti-diabetic cautiously, and SGL inhibitors are soon going to be must agents. That this is a word written, this sentence is written quite some time back. Today, SGLT2 inhibitors, you are supposed to prescribe to all your patients of heart failure and diabetes, heart failure without diabetes, and all diabetic patients who are prone for heart failure are prone for CVD. Thank you very much.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I hope, sir, this topic knowledge is going to help all the participants who have joined this session, sir. Sir, as I can see, sir, there are like one question from one of the participant, Dr. Anshuman Singh. He is asking like, what are the role of lifestyle in correction of diabetes and cardiovascular diseases?
Well, lifestyle has a big role. We all know lifestyle has a big role in preventing diabetes. Lifestyle has a big role in postponing diabetes if you are prone for diabetes. Let's say your mother is a diabetic or your father is a diabetic, and in many patients' families, you see both parents having diabetes. And in all of them, you follow good lifestyle, you may prevent diabetes or at least postpone diabetes. Let's say I postpone my diabetes by 10 years or 15 years, my prognosis correspondingly improves greatly. And therefore, lifestyle has a big role not only in preventing but postponing of diabetes. And then once diabetes sets in, lifestyle makes a big difference in terms of control of diabetes. So lifestyle is always important. Drugs are important in the current scenario of busy life, people running around. Let's say a doctor, he is so busy, he may or may not find time to exercise. All of them, in probably in this today's busy world, people find it difficult to do their exercise. I agree with it. Drugs become a very important part of our treatment. At the same time, one should never forget that lifestyle has given a great big difference. There is any amount of data from trials showing that those who follow aggressive exercise, aggressive diet reduction, aggressive management of diabetes, they tend to gain greatly in terms of reduction of the major vascular events, or for that matter, microvascular events also. There is a very good trial which has told us, this is a trial done in England among patients of diabetes. You know, English patients are very disciplined patients. This is done in 2010, 11 or so. And what they have found is that if you control your diabetes by whatever means and bring down the A1C to less than 7, you control the blood pressure and bring it to less than 130. And if you control your LDL and bring it to less than 100 and don't smoke, 3 controls of ABC and don't smoke, your chances of getting worse over course of years is only slightly different from non-diabetics. So while I'm talking so much bad about the prognosis of diabetes, let me also end it by saying that things are all not that bad. The data is all in the earlier days data. Those days we did not know the importance of controlling A1C. We did not know the importance of controlling blood pressure. We did not know the importance of controlling LDL. Today, you are armed with knowledge. You have so much data, that diabetic patients, if they follow aggressively good lifestyle and take care of their ABCs and do not smoke, their prognosis is only slightly worse than the non-diabetics. So that's a very, very good point that has come. This trial, I suggest all of you to read. It's called the Ascend trial. It was not done with the intention of looking at diabetic outcomes. They did it with the intention of looking at use of aspirin as a primary prevention. But then this data came out as a sideshow, but it was very, very impressive. So I suggest you look at the data. Not only Ascend, there is a lot of other trials also, which showed that lifestyle makes a big difference. There is another trial done among veterans in US, where those were all patients who were very sick multiple times. You know, veterans in US are people who have a bad lifestyle, high risk of smoking and all. And then they had multiple CV events. And then they caught hold of those fellows and then randomized them to aggressive control of diabetes by means of exercise, by means of control of diabetes using the pharmaceuticals, and of course diet. And they showed that even at a late stage, as that veterans trial, that if you follow good lifestyle and all these things, the prognosis becomes considerably better compared to those who have average control of diabetes. I am not able to recollect the name of that particular trial, but let me tell you that lifestyle is very, very important. Control of ABCs is important. Yeah.
Yes,
Thank
sir.
you.
Very well said, sir. Like, I hope that Dr. Anshuman has received his answer, sir. Sir, one more, he is adding the points like, according to you, sir, what are the three lifestyle modifications should be focused on in curing diabetes at home? 3 points. What will be you mention, sir?
Very good. Very good question. The first and foremost is exercise. Probably exercise is the most important thing. Let's not use the word curing diabetes at home. Curing is, once diabetes has set in, curing it is a relatively long shot. Probably if you do a bariatric surgery for an established diabetic patient, that kind of cure is possible. But large majority of the patients, cure is not achieved because of the usual thing. But control of diabetes can be achieved. Most important is exercise, of course, diet reduction, and I would say one cannot live without pharmaceuticals. The medications are required. Medications, exercise, diet control. These three things, ask them to do. That would be a very good way of achieving control of diabetes and the attendant complications. Yeah.
Thank you so much, sir, for answering it really well and allowing that Dr. Anshuman is writing. Thank you so much for enclosing with the insights of this topic. As sir, I can see there is no more question from the participant. And sir, can we conclude this session with all your permission, sir?
Yes. Thank you so much. Thank you.
Okay, thank you so much, sir. And it was really glad to have you, and you have spared your precious time among the audience, sir. I hope that it will be a very impactful to each of one of us lives, sir. Like, it is very important to get a correct knowledge from the healthcare professional, sir.
How many people have attended this talk?
I can see, sir, like live, I can see 59 people were watching that time, sir.
Okay.
Right now, the still count are there. It will be posted and the count will be increasing time to time, sir. And thank you so much once again, sir. And I would like to see you again with different topic in coming time, sir, in future.